Welcome everyone to today's webinar, The Future of Payment Reform, Why Providers Can't Afford to Ignore BPCI Advanced Cohort 2. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. When we reach each poll slide, the poll question will pop up automatically on your screen. Our speakers will give a few seconds for you to select an answer from the options on your screen and click Submit. Thank you in advance for your participation. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Keely McMillan is the General Manager of BPCI Advanced for Archway Health. In her role, she oversees all aspects of Archway's involvement in the Bundled Payments for Care Improvement Initiative from CMS. She is a recognized expert in alternative payment models and health policy with more than 10 years of healthcare experience in guiding providers to success in ACOs, bundled payments, value-based purchasing, and MACRA's quality payment program. In other roles, including Manager of Government Payment Policy at Partners Healthcare, Keely has analyzed performance-based reimbursement models and worked closely with healthcare leaders to develop system-wide public payer strategies. She earned a master's degree in health policy and management from the Harvard T.H. Chan School of Public Health and a bachelor's of science from Yale University. At this time, I am pleased to turn the floor over to Keely to begin today's presentation.
Great, thanks very much, and thanks everyone for joining us today. I'm Keely McMillan. I'm the General Manager of BPCI Advanced at Archway Health, which is a value-based care solutions company based in Boston. We also have offices in New York. In the last few weeks and months, really, CMS's Center for Medicare and Medicaid Innovation has pushed through an abundance of voluntary value-based care initiatives. They finalized the overhaul of the Medicare Shared Savings Program called Pathways for Success. They announced the ET3 model, the Emergency Triage, Treat, and Transport model. They've greatly expanded the Primary Care Transformation Initiative to include 5 new options, which includes the direct contracting model. They recently reopened the window for the Bundled Payment for Care Improvement, or BPCI Advanced program, and there's more in the pipeline. We're anticipating the announcement of a radiation oncology bundle this summer. We're also expecting the announcement of cardiac bundles. I think we'll see the cardiac EPMs, or episode payment models program, come back into play. And we're also expecting an update to the mandatory CJR, the Comprehensive Care for Joint Replacement program, which has thus far been found to be successful. And I think a lot of folks thought, or at least wondered, if the pace of value-based care might slow when the administration changed hands, but really we've seen quite the opposite. And while certainly a lot of that is driven in part by strong and genuine commitment to improving the quality of care provided, and we also have no choice. The latest Medicare Trust Fund report projected Medicare, or at least Medicare Part A, would be insolvent in 2026. So CMS has no choice but to find ways to reduce costs and increase the value of care being provided. And while many risk programs that CMS is launching today are still voluntary, with that trust fund, as that trust fund moves closer to insolvency, upside-downside risk programs will eventually be universally applied. So in today's webinar, we're going to dive into how providers can assess and manage their opportunities and risks in upside-downside risk models. And we'll look at that through the lens of BPCI Advanced. And CMS has reopened the window to enroll in the program, which is a great opportunity for providers to kind of dip their toe in the water of value-based care. So we'll start with some highlights of the BPCI Advanced program and review the timeline for Cohort 2, for the Cohort 2 application process, and then we'll also review the target pricing methodology for the program. But what we really want to spend most of the time is on diving into the key questions you really want to be thinking about as you evaluate your opportunities and risks. There are risks of participating in downside risk models, and we'll talk about ways to mitigate your risk and protect your downside. But there are also risks of sitting out. Medicare has stated its intent to have 100% of providers bearing risk by 2025, and that will include through the implementation of mandatory risk-based programs. So we'll look at why providers cannot afford to ignore these opportunities to prepare for that. And then lastly, as was mentioned, we're going to conduct a handful of anonymous polling questions that we'll kindly request you to respond to. And this is just to give us a sense of where you're coming from, how you're thinking about bundle payments, and of course we'll share those results so you can see where your peers are coming from. And we're actually going to jump right in with our first poll question, which is, what is your organization's current participation status in BPCI Advanced? Are you currently participating in the program? Did you apply but didn't go forward for whatever reason? Maybe you did go forward but you dropped out of the program on March 1st of this year. Perhaps you have no experience in BPCI Advanced at all, or perhaps you don't know what your organization's participation status is, or it's maybe not applicable. Folks could submit their answers here. Great, thank you very much for your participation. So we have about a third of participants who are currently participating in the program. Another 9 to 10% applied to the program but didn't go forward. Interestingly, we don't have anyone participating in this webinar who dropped out entirely on March 1st. And then about a third have no experience with BPCI Advanced, and then another handful either don't know or it's not applicable to their organization. That's helpful information for us to have. Thank you for participating in that polling question. So I'm going to start with just a little bit about Archway Health. We are a value-based care solutions company that was founded over 5 years ago, and our mission is simple: to fix healthcare through payment reform. And we're really passionate at what we do. Our team has been working in bundled payments since their inception 12 years ago. Our leadership specifically has significant experience in Prometheus and other commercial models, and Archway as a company has been involved in all of Medicare's bundled payment programs. We were a convener in BPCI Classic. We are a convener in BPCI Advanced. We've also helped a lot of our clients be their own convener or manage their own contracts with CMS. We work with hundreds of providers across the country, including in the CJR program, the oncology care model, and we have real verified results. Across the board, our practice partners are saving an average of 9% versus baseline costs, with certain groups saving up to 16%, and this translates to an average of $3,000 in savings per case. Now, as I mentioned, our leadership has been working on bundle payments for over a decade and has been involved in BPCI since its inception in 2011. And we've taken our experience and honed a successful bundled payment solution that combines strategic planning, analytics, real-time patient tracking, real-time care management, real-time performance tracking, and program management that allows providers to take control of their risk and improve the quality of care being provided for their patients. We also provide risk financing and resources for structuring alternative payment model financing. And we really strive to meet providers where they are. The journey from fee-for-service to value-based care isn't straightforward, and providers are at different points along that journey. In BPCI Advanced, for example, we work with some providers as their convener, which means we apply to the BPCI Advanced program on behalf of our provider partners, and we have a contract directly with CMS and handle all administrative, compliance, financial reconciliation, payment issues with CMS on behalf of our provider partners. And in these arrangements, we share risk. We share financial risk with our provider partners. So we don't make money unless they make money. But we also work with a lot of providers in BPCI Advanced who are their own convener or have their own contract with CMS. And this was the case with BPCI Classic as well. And in these arrangements, providers might just license our tools. Our Archway Analytics tool, for example, which is a cloud-based Tableau platform that's secure, that calculates patient-specific target prices. These are risk-adjusted target prices for each and every patient who triggers a bundle in the program. We have our Archway Opportunity Assessment tool, which can tell you what your risk is of gaining or losing money in the program. And we do all this on behalf of our providers so they can focus their time on providing and improving care to their patients and not wrangling claims data. There are also some providers who do everything in-house and are simply looking for stop-loss protection to ensure they never have to write a check for more than a certain amount, and we can help providers navigate that as well. So next we're going to review some highlights of the BPCI Advanced program as well as a timeline for the cohort to application period. But I want to start with why CMS is doing this program and why you really want to secure your option to participate. And I think it's been well demonstrated that fee-for-service reimbursement does not reward or incentivize providers to coordinate care across the continuum, nor has CMS historically given you the information you need to do so. And so it's no surprise that care has become quite fragmented and post-acute care has been largely unmanaged. And as a result, it's no surprise to see such wide variation in spending, not only nationwide, but within local regions as well. Archway has Medicare fee-for-service claims data for all providers in the country, and we've built a bundled payment claims engine, so to speak, an analytics platform so that we can run all that data through our analytics platform and analyze variation and opportunity for cost savings for all providers nationwide. And just to give you an example of that, what you're looking at here in the orange heat map is the interquartile variation within a state. So that's the difference between the 25th percentile and the 75th percentile of average spending within a state. And in this case, this is for a 90-day episode that's triggered by MSDRG 470, so major joint replacement of the lower extremity without complications and comorbidities. And in Texas, if you can see, for major joint replacement of the lower extremity, the difference between the 25th percentile of spending and the 75th percentile of spending is $12,000. That's a 40% variation between the most efficient quartile and the least efficient quartile. And we have seen in the data that this variation in particular is driven by average post-acute care spending after major joint that ranges at the state level from $5,000 to almost $13,000 at the state level. That's a threefold variation. And we see this type of variation in every metropolitan statistical area in the country, and this is a reflection of fee-for-service reimbursement and gets at the root of why CMS is developing this voluntary program. They really want to recruit innovative, progressive, talented, motivated physicians and hospitals to find ways to reduce costs and then reward them for it. It's designed under the premise that having a provider own, say, a $25,000 bundle would lead to efficiencies and care redesign. The bottom distribution graph shows average bundle spending for major joints nationwide, and you can see the bell curve is skewed to the right. It has a positive skew, reflecting a lot of expensive cases which drive up that average spending. And this long tail you see on the right is a reflection of that wide variation in what Medicare pays for a 90-day episode of care triggered by major joint replacement of the lower extremity. And this really gets at why Medicare is doing this program. They're trying to get innovative providers to find ways to reduce unnecessary variation and to have a bell curve that's not so skewed to the right. So let's look at the basic mechanics of BPCI Advanced. A bundled payment is a single payment made to providers for all services rendered in a clinically defined episode of care. And during that episode of care, a provider is responsible for managing all of the costs associated with that episode. And this is a discrete episode with a defined start date and a defined end date. It starts with a trigger event, which is usually an inpatient admission, and ends 90 days after discharge. And in that 90-day time period, all costs are included in the bundle. So that includes the inpatient admission itself, that trigger event, and all post-acute care, whether that's at a skilled nursing facility, an inpatient rehab facility. It includes home health care, Part B professional service revenue, any testing that's done in the hospital outpatient department setting, any physician's office visits. It also includes any readmissions, any emergency visits, any observation stays. And there are some exclusions that apply, including readmissions for trauma or cancer-related care or organ transplant. But for the most part, all costs are included. And as far as how providers can earn revenue in the program, let's say a provider is given a $25,000 target price for a hip replacement. And that's to cover the anchor admission, that anchor procedure, and all spending that occurs in the 90 days after that procedure. If spending for that 90-day bundle comes in under $25,000, the provider would keep that savings. And if the spending were to come in over $25,000, the provider would pay back this difference. And the savings or losses being in the form of repayment, would be done at the aggregate level. And we kind of think of the specialist as the quarterback responsible for managing this entire episode. You know, in our experience, you get best results when you have strong specialist engagement. So let's review some key takeaways of the BPCI Advanced program. Now, this is a voluntary program that has both upside and downside risk. This program pertains to traditional Medicare fee-for-service patients only, so those are beneficiaries enrolled in Part A and B. It excludes patients in Medicare Advantage or commercial programs. The program runs from October 1 of 2018, so last fall, through the end of 2023, so that's 5 years and 1 quarter. The first cohort went live October 1st of 2018, and now CMS is opening up the window for the second cohort, which will start January 1 of 2020. And at this time, they do not plan to open the window again. So it's really now or never to at least get your data and look at your opportunity in the program. And I do want to note there are multiple options to drop from the program, including at the end of 2020. So if you start 1/1/2020 with Cohort 2, you can drop at the end of the year. So essentially, this would be a 1-year time commitment. You don't have to commit for a full 4 years. Starting in 2020, there are 37 total bundles in BPCI Advanced. Most of them are inpatient, though there are several outpatient bundles as well. BPCI Advanced is considered an advanced alternative payment model under Macro's Quality Payment Program. So an additional benefit of participating in BPCI Advanced is that for physicians who have enough volume attributed to the program, physicians can qualify for an automatic 5% lump sum bonus on all of their Medicare Part B professional service revenue and be exempt from MIPS, which can carry substantial reporting requirements and downside risk. And even if you don't have enough revenue in BPCI Advanced to qualify for that 5% bonus, because those thresholds, those volume thresholds are very high, you can still benefit from favorable scoring under MIPS. BPCI Advanced does have a more sophisticated target pricing methodology, which we'll look at more and closely in an upcoming slide. What's convenient is providers in BPCI Advanced still bill and get paid as normal. The providers are not actually given an upfront lump sum of money. They still bill and get paid as normal. And after the performance period is over, CMS goes through and adds up all the claims associated with patients in the program in this process called reconciliation and determines in aggregate what the savings or losses are. And those savings or losses can be up to 20% of your target price in aggregate at the episode level. So there's some real upside and some real downside. With regards to the timeline for the Cohort 2 application process, the non-binding application is due June 24th, 2019. And it's really important. We really emphasize that providers at least apply to the program because it's non-binding. Just because you apply doesn't mean you have to go forward in the program. and it buys you more time. You know, you don't have to decide until November of this year whether you want to participate or not. So if right now you're not in a position to make a decision about participation, at least buy yourself another 5 more months of time to make that decision. But really a huge benefit of applying is CMS gives you your data, this 3 years of historical baseline data and your target price. And this is really rich intelligence that can be used to identify opportunities in BPCI Advanced as well as other strategic initiatives as well. Now, during this sort of pre-application time, we really encourage you to start identifying preliminary opportunities to earn savings in the program, and this can be done using claims data Archway has. And we also encourage you to start engaging stakeholders and educating key leaders in your organization about these opportunities for new revenue and improved patient care, so that in September, when CMS provides applicants with their detailed claims data and target price, you're in a better position to be able to make a decision quickly. You know, CMS has already told us the timeline for Cohort 2 will be tight. Applicants who submit a non-binding application or are listed on a convener application June 24th will get their data and target prices in late November. And we'll have to make a decision about participation in November. So that's a pretty tight turnaround. But if you're well organized, you know, this timeline is manageable. We've done it before. So in the meantime, as you're waiting to get your target prices, be thinking about how you want to structure gain sharing arrangements, how you're going to finance your risk. You know, which preferred post-acute care providers are the best to partner with? Who's going to be your physician champion? How are you going to engage specialists, and some other important activities that Archway can help you with. Now, once you get your claims data and target prices from CMS, we strongly recommend you do a comprehensive opportunity assessment and go through a strategic bundle selection process in which you consider factors such as volume, pricing advantage, and benchmark opportunity, which we'll get into in a moment here. You'll have to make a decision in November as to whether you want to participate, and if so, which bundles you want to be at risk for. In BPCI Advanced, what's convenient is you can pick and choose which bundles you want to be held at risk for. And then at that time is also when you'll execute a contract, whether that's with a convener such as Archway or with CMS, depending on how you choose to participate in the program. And then you'll need to implement a care redesign as well, and tools to help you be successful, including an analytics tool and patient tracking tools. Many providers at this time will also want to have their preferred provider networks in place and set up gain sharing agreements with physicians. And then Cohort 2 will commence on January 1 of 2020, at which providers will be at risk for their performance. Now, perhaps the most sophisticated aspect of this program is the patient-specific risk-adjusted target pricing methodology that CMS has introduced with BPCI Advanced. To calculate target prices, CMS starts with 4 years of historical baseline data, and for model year 3, which is correspondent with Cohort 2, which begins on January 1st of 2020, the historical baseline period will be October 1st, 2014 through September 30th, 2018. So for hospitals, this is the federal fiscal years 15, 16, 17, and 18. To that historical baseline period, CMS applies a 3% discount. So that's essentially 3% guaranteed savings to Medicare that they make on every payment that's made for in-bundle payments. But after that, CMS then makes a bunch of adjustments on top of that. CMS actually takes into account patient-specific comorbidities and risk factors for patients who are live in the program to set patient-specific target prices. So they take into account the patient's age, if he's eligible for Medicaid, if he lives in a nursing home, a long list of comorbidities including diabetes, COPD, heart failure, AMI, heart conditions, major depression, so on. And this risk adjustment, it does make the program more complex, but in doing so, it both mitigates to some extent the incentive for providers to cherry pick patients or divert complex patients away, and it also more fairly acknowledges the cost to providers of caring for sicker populations. And for providers working with Archway in this program, we calculate patient-specific target prices for each and every patient attributed to the program based on the claims data, that rich data we get from CMS, that CMS provides, so we can accurately project dollars gained or lost on a bundle-by-bundle basis. Now, CMS also applies what's called a peer-adjusted trend factor that adjusts the target price to reflect characteristics of the episode initiators peer group. And when I say episode initiators, these are the provider, this might be a physician group practice or a hospital that is initiating episodes in the program. CMS adjusts that episode initiator's target price to reflect characteristics of that episode initiator's peer group. And this is new for BPCI Advanced. This was not done in BPCI Classic. Specifically, for BPCI Advanced target pricing, CMS created 288 peer group combinations with unique peer-adjusted trend factors for each bundle. So there's actually over 10,000 peer-adjusted trend factors for all the different peer groups, for all the different bundles. And there are 5 characteristics that CMS uses to create these peer groups. The characteristics are, 1, which region is the episode initiator located in? And when I say region, these are based on the 9 U.S. Census regions shown here on the map. And then CMS also takes into account urban versus rural setting, the hospital is a health safety net hospital, the size of the hospital, how many beds the hospital has, and then whether or not it's a teaching hospital, an AMC specifically. And this pricing, which takes into account both regional spending and the episode initiator's own historical performance, creates both opportunities and risks. And that's what we're going to delve into next. How should you be thinking about those opportunities and risks when you get your data and target prices from CMS in September? First, though, we're going to do another poll question, which is, does your organization currently have a method to protect its downside risk? Yes, no, I don't know, or maybe it's not applicable. Great, thank you for participating in that. It looks like about a third do not have a method to protect downside risk. A third don't know, and for a third it's not applicable. Interestingly, and maybe I didn't leave it open long enough, but no one answered that they do have a method to protect downside risk. So that's what we're going to look at next. As I was mentioning when I reviewed the timeline slide, those who submit a non-binding application by June 24th, or those who are listed on a convener application by June 24th, or those who are already participating in the program today, CMS is going to send you 3 years worth of historical baseline data from the time period of October 1, 2015 through September 30th of 2018. So that's 3 years worth of historical baseline data, as well as preliminary target prices, and that'll come in September. And what I want to walk through are some of the high-level questions you need to be asking when looking at your data and your target prices. These are all questions that Archway can help you answer, and questions Archway helps our provider partners answer. For starters, how do your episode prices compare to your historical performance? And does your recent performance create opportunities versus baseline? The baseline period being federal fiscal year 15, 16, 17, 18. If you've made changes since then or on the back end of that time period, that could generate a price advantage for you in the program. In other words, you could already be beating the target price right out of the gate, and we'll look at that more closely in a moment. You want to be looking at, does your performance versus the regional and peer benchmarks create opportunities for you? In other words, how do you compare to your peers in your region when it comes to, say, readmission rates or ED visits or unnecessary post-acute care utilization? Services done in a hospital outpatient department setting that could be done in a more cost-effective setting such as an ambulatory surgical center or physician's office. And this is an area where Archway can be really helpful helpful, even providers with the most sophisticated of analytics teams don't have all claims data for all the other providers in their region to be able to see how they perform relative to others over time. Looking at your data in a vacuum has some real limitations, which is why Archway created BPCI-specific benchmarks to give providers an understanding of what their spending looks like in a bundle compared to peers in their area. Some of the other questions you want to be asking are, what are the probabilities of success in each bundle, and what are the actionable levers that can impact that probability of success? What can you start doing today to increase your likelihood of earning savings in the program? Being able to answer these questions, these key questions, is critical to being able to make an informed decision on strategic bundle selection. Which bundles create the highest value and present the lowest risk. Beyond volume, you want to have enough volume, obviously, to justify the ROI as well as to spread the risk. But beyond that, you want decent pricing. You want your most recent performance to be as close to or ideally beating the target price. And you also want decent benchmark opportunity. So let's delve into these questions a little further with some data examples. I mentioned that the target prices are set by 4 years of historical baseline data. And if you've made recent improvements in performance or improved in the back half of that time period, that can create a pricing advantage in model year 3, which starts January 1 of 2020. And just as an example, on the left-hand side of the slide, you can see a 5-year performance trends for a de-identified episode initiator, and this is for this sepsis bundle. In red, in that red trend line, you can see the 90-day average readmission rate, which for this particular episode initiator was over 50% for most of the baseline period, but then started to come down most recently in 2018. Again, this is for a sepsis bundle. In orange, you can see the SNF utilization rate, or the percentage of patients who went to a SNF during that 90-day performance period, has come down since 2014, but stayed relatively flat through the rest of the baseline period. You can see in black the risk-adjusted 90-day mortality rate has fluctuated to some degree. And then you can see in yellow at the bottom, the utilization of inpatient rehab has declined from 17% in 2014 to 8% in 2018. And the decline of the readmissions and inpatient rehab, both of which are high-cost levers, has generated a pricing advantage for this episode initiator in sepsis. On the right-hand side, you can see the episode initiator's corresponding spending trend over that same time period. So the gray line represents what CMS actually spent on this 90-day sepsis bundle over the 5-year time period. So it started around $55,000 per bundle in 2014 and declined to around $47,000 per episode in 2018. So overall a decline. The teal line represents what that spending was after being risk adjusted for patient severity, so that you can look at that trend over time, apples to apples. And for BPCI Advanced, CMS uses the Medicare Advantage 2017 risk adjustment methodology. This is the HCC risk adjustment methodology. Because this episode initiator's performance has improved over time, this creates a pricing advantage in BPCI Advanced because the episode initiator is now beating the projected target price, which is shown in red. So that red dotted line going across is the projected target price, which is around $50,000. And the provider's most recent spending in 2018 is below that target price. So in this scenario, the episode initiator would be making money today by doing what it's currently doing. And then that pink line you'll see represents the price trend for this episode initiator's peer group. So that's the peer-adjusted trend factor, which is going up over time, somewhat consistent with overall Medicare spending in general. Now, pricing advantage is not enough to make a recommendation about whether or not to take risk in this bundle. We also have to look at benchmark opportunity, or opportunity to achieve further savings. If you're right at the target price, but there's no more opportunity to achieve any more savings, that's not a favorable scenario because it's going to be very difficult to earn NIPRA or savings in the program. So to evaluate benchmark opportunity, we calculate regional benchmarks based off the most efficient 20% of providers in a given region for a given bundle and compare your historical spending to that regional benchmark. So let's just say, for example, that your historical spending for AMI was $25,000. And among the most efficient 20% of providers in your region, the average spending for AMI was $21,000. That would be a $4,000 worth of benchmark opportunity in this bundle. Now, what's good about that is that you have opportunity to achieve savings, and you've got fat to trim, so to speak. If you're already at the benchmark because you're so efficient, that might be problematic if you're right at the target price, for example. If you're already breaking even but you have no more fat to trim, that's probably not something we'd recommend taking on risk for. Archway has a really sophisticated team of data scientists who have calculated statistically sound regional benchmarks for all bundles in BPCI Advanced. And this regional benchmarking is critical to identifying actionable opportunities for improvement. And as an example of that, what's shown here is a sample of hospitals in the state of Florida and their performance in a 90-day COPD bundle. And now these hospitals have been de-identified, and they're sorted by volume, which is shown in the first column in blue. In the second column in teal, you can see the average spending for the 90 days following that initial discharge from COPD varies between $14,000 and $20,000 among these hospitals. And that's driven by variation in readmissions, shown in red. The readmission rates, the average 90-day readmission rates among these hospitals range from 37% to 51%. There's also a twofold variation in ED rate, almost a twofold variation in SNF utilization. And then SNF average length of stay across the board is quite high, but some variation there as well. And then a little bit of variation in inpatient rehab utilization, with some hospitals using up to 12% utilization and other hospitals being at 1%. And not all of this variation can be justified clinically. Across the top, you can see the regional benchmark, or the performance of the most efficient 20% of providers in this region for COPD. The readmission rate among those top performers is 34%, still seems high. The ED outpatient rate is 39%. SNF utilization, so the percent of patients who go to a SNF, is 26%, and on average, they say they're 29 days. If the hospital on the first row were to be able to meet the benchmark, in other words, reduce readmissions and SNF utilization to meet that of the benchmark, this hospital could earn $3,400 per case in COPD in this program. And with a volume of over 1,000 cases per year, that translates to quite a bit of upside revenue. Now, here's another example of how regional benchmarking can be used to identify actionable opportunities for improvement. The pie graph on the left-hand side is showing the discharge disposition for major joint replacement of the lower extremity from a de-identified hospital. And you can see in green, that represents home health, so patients who are discharged home with home health services. This particular hospital sends about 50% of patients home with home health after major joint replacement of the lower extremity, and about 42% of patients home with skilled nursing, and then a few patients home with inpatient rehab, and a narrow number of patients home without any home health services. Well, compared to the regional benchmark for this provider sends a greater proportion of patients home with home health services and a smaller proportion of patients to a skilled nursing facility. A day in a SNF is, on average, maybe $500 per day. And so patients who are going to SNFs and staying for a long time, might be an opportunity for cost reduction. If you think about it, if you're able to lower average length of stay in a skilled nursing facility by 4 days, that's $2,000 in savings that you could earn in this program. So this is another way in which seeing how you compare to your peers in your region can help identify actionable opportunity. And in this particular case, the provider, if they were to meet the benchmark as far as how much SNF utilization and home health utilization, the provider could earn $2,000 per case in BPCI Advanced. Archway also combines regional benchmarking with predictive analytics to calculate the probability of gains or losses in the program. So in other words, if you were to do nothing, what would be your probability of gains or losses? Or if you were to impact performance by a certain amount, what would be your probability of gains or losses? And importantly, what would it take to break even in the program? And to show an example of that, the trend lines you see here represent two de-identified hospitals that are part of the same system in Alabama, and those are differentiated by the orange and blue lines. And this is for a 90-day sepsis bundle. The graph on the left displays the probability of loss depending on how much of the benchmark opportunity is achieved. So when I say how much of the benchmark opportunity is achieved, I mean how much have you closed the gap between where you are and where the most efficient 20% of providers are in your region for this bundle. If your average spending is $25,000 for a given bundle and the most efficient quintile in your region has an average spending of $21,000, that's $4,000 of benchmark opportunity. If you were to lower spending on average by $1,000, you would be achieving 25% of that benchmark opportunity. You would be closing that $4,000 gap of opportunity by 25% if you lowered spending by $1,000. So in the graph on the right, you can see for sepsis, for hospital A in blue, if that hospital were to do nothing, in other words, if its performance were to stay the same, its probability of loss is quite high. It's 77%. And this hospital would have to achieve almost 20% benchmark opportunity to lower its probability of loss to less than 50%. Now, if hospital A in blue were to achieve 40% of the benchmark, that probability of loss becomes pretty low. It comes down to 10%. And on the right-hand side, you can see how that probability of loss translates into dollars and cents. Still looking at the hospital A in blue, if the hospital were to do nothing, its performance staying the same, it's predicted to lose $681 per case. If it were to achieve 20% benchmark opportunity, it would more or less break even. And if it were to achieve 40% of the benchmark, it would earn almost $800 per case. So for hospital A, the benchmark break-even percent, in other words, how much of the benchmark has to be achieved to break even. For hospital A, that's right around 20%, which is it's certainly achievable, but if you get to a benchmark break-even threshold of above 30 or 40%, that can start to get risky. Now, a benchmark break-even percent will be really high if your organization is either really efficient or really inefficient. Now, for hospital B in orange, sepsis is a much more favorable bundle. So back on the left-hand side, you can see by doing nothing, by maintaining current performance, the hospital B in orange has a 32% risk of losing money. So said another way, hospital B in orange has a 68% risk or probability of gaining money by doing nothing. And if the hospital further drives down spending and closes the gap between the hospital and the most efficient quintile in the region, that risk goes down to almost zero. Translated into dollars on the right-hand side, by doing nothing different or maintaining current performance, the hospital would earn $441 per bundle, and that could go up to $1,800 per case by achieving 40% of benchmark opportunity. And with that, we want to ask another poll question, which is, would you like to know how you perform compared to peers in your region? Either yes or no, it will not impact your decision to participate. Thanks very much for participating in that. It looks like 2/3 would like to know how you perform compared to your peers in your region. Archway would be more than happy to show you that. And then another third say it would not impact your decision to participate. So that's helpful. Thanks very much for responding. Now, data is not the whole story. There are key qualitative questions you want to be asking in tandem with looking at your data. And that's to gauge your foundation for success or exposure for losses. These qualitative questions include, are there appropriate resources in place to support the program? Do you have executive sponsorship? Do you have a knowledgeable program manager? Do you have dedicated care coordinators? Do you have physician leadership? Anecdotally, we worked with a few providers in Cohort 1 who were not able to allocate proper resources because of competing demands at the organization. In one case, it was the implementation of a new EMR. In another case, it was the merger of multiple practices, and they just weren't able to get the appropriate resources in place, and it really increased their risk in the program such that they actually dropped out on March 1st. Some other qualitative risk factors might be, do you have stakeholder buy-in on what you've identified to be actionable levers for success? If, say, one of the strategies to reduce ED visits is by having extended office hours or a 24/7 hotline, do you have buy-in from clinicians to be on call those extended hours? If one of the strategies to reduce ED visits is to ensure patients have same-day clinic access for symptom management, are your schedulers and administrative boots on the ground, so to speak, on board with this? Do you have a steering committee in place to review progress against set performance metrics? Do you have an incentives or a comp model that is aligned with these performance metrics? Now, this is huge. Do you have a process in place to identify patients in the program? It's really hard to track your patients in the program and intervene if you don't know who they are. So, what percentage of your BPCI advanced patients are you able to identify in real time as confirmed in the claims data? These are all the types of questions you want to be folding in when you look at your data so that you're evaluating a full picture of your risk. Now, there are risks of participating in BPCI Advanced and another downside risk arrangements, and there are steps you can take to mitigate those risks. But there is also a risk to sitting out of these voluntary alternative payment programs. CMS is increasingly using regional trends to set target prices and risk arrangements. They use it in the Comprehensive Care for Joint Replacement program. They used it in cardiac EPMs. They're applying regional trends in BPCI Advanced. The oncology care model uses the Dartmouth Atlas hospital referral region. The new geographical direct contracting model incorporates regional trends. And the rising participation of providers in alternative payment models, or APMs, including bundled payments, including ACOs, including primary care risk arrangements, that is expected over time to drive down regional spending. And providers who sit on the sidelines of value-based care initiatives will fall further and further behind the curve and be really disadvantaged when risk models are mandated and the pricing is set by your peers who are now more efficient than you are. So if you think about it, the success that others have in risk models today will dictate your pricing and mandatory programs tomorrow. To use the analogy of being chased by a bear, you don't have to outrun the bear, you just have to outrun the guy next to you. Well, providers going forward in risk arrangements today have already started running, and you cannot afford to get too far behind because their efficiency is going to dictate your pricing. One example of that we've already seen play out in the market is with major joint replacement of the lower extremity. Through BPCI Classic, in which orthopedic surgeons were generating significant savings, the Comprehensive Care for Joint Replacement program, which thus far has proven successful, ACOs and other value-based care programs, the spending curve for major joint has aggressively trended downwards. And what's shown here are the actual trends in major joint replacement of lower extremity spending for all 9 U.S. Census regions. And this is specifically for the peer group of medium-sized hospitals in urban areas that are not AMCs or safety net hospitals. And each line you see represents the peer group in each of the 9 U.S. Census regions. And you can see across the board the peer ratio, which is a regression of observed to expected spending for the peer group, is declining in all regions. The punchline here is spending for major joint replacement of the lower extremity is going down nationwide. A little earlier we talked about the target prices using a peer-adjusted trend factor. Well, that peer-adjusted trend factor is this peer ratio of observed to expected spending, which is being trended forward. And we picked this peer group as an example to show nationwide apples-to-apples comparison, but we see this downward trend among all peer groups nationwide, with some exception for real rural hospitals, rural peer groups. We've also started seeing this trend play out in other episodes of care as well. Another example of that is hip and femur procedures. What's shown here are the actual trends in hip and femur spending. And this is an example of a peer group for large urban hospitals that are neither AMCs or safety net hospitals. And I've highlighted 2 peer groups just as an example. One is Mid-Atlantic and one is West-North Central. And you can see for both peer groups, they started in the same place and are both trending downwards with regards to observed to expected spending, but West-North Central peer group is trending down a little more aggressively. And these are real trends, and there are other bundles in which we're starting to see downward trends as well, and this includes congestive heart failure and COPD. And this is an illustration of what will happen if you choose to sit on the sidelines while your provider peers drive down the spending curve. The dark blue line represents the trend for your peer group, which is declining over time as providers get more efficient at providing any given service. And that gets further catalyzed by active participation in APMs. And the light blue dotted line represents you if you do nothing. You may directionally trend on par with the market as you slowly regress towards the mean, but you're going to get further and further behind as your peers who are driving down the trend. And eventually, CMS is going to use this regional trend to set prices, to set reimbursement. In other words, CMS is going to pay you the price set by your more efficient peers. And that will be a major hit to your margin when overnight you're getting reimbursed at a much lower level than what you had been. And this will happen. CMS has stated its intent to have 100% of providers bearing risk by 2025, and that will include through the implementation of mandatory risk-based programs. So you really want to get ahead of this and be prepared for risk-based arrangements through experience in voluntary programs such as BPCI Advanced. What's convenient about bundles is instead of trying to boil the ocean and be at risk for an entire population, as you might with an ACO, for example, bundles allow providers to take on risk for a narrower population and kind of get their feet wet before taking on a greater portion of risk for a larger population. Medicare bundles also provide a good vehicle to prepare for success in commercial and increasingly employer risk arrangements. Medicare thus far has been the primary catalyst for driving downside risk models, but commercial payers and particularly employers are becoming increasingly active in this space, and having experience and data from Medicare programs can help providers set a strong foundation for success with other payers. Now, let's look at one more example of the trend and what Medicare is paying for a given service. And in this case, this is inpatient PCI, percutaneous coronary intervention triggered in the hospital inpatient setting. Spending for this bundle is increasing, so this is in line with overall Medicare spending nationwide, which continues to increase. But we are starting to see this increase in spending start to plateau in some areas. In New England, for example, where there's been a very high concentration of providers in ACOs, including Pioneer ACOs, NextGen ACOs, Shared Savings Program ACOs, the trend of observed to expected spending is starting to decline, actually. And in East North Central, that has started to plateau. And the point here is, while these peer groups in different areas all started at the same ratio of observed to expected spending, they've trended differently over time. New England has bent the cost curve, and West South Central has not. And when CMS starts paying for inpatient PCI at a price that's been driven down by others that are ahead of you, you don't want to be way above this price point. Again, this is an illustration of What will happen if you choose to sit on the sidelines while your provider peers drive down the spending curve? Again, the dark blue represents the trend for your peer group, and that curve will continue to bend through increased participation in APMs. And that light blue dotted line represents you if you do nothing, and you're going to get further and further behind your peers who are driving down the trend. And when CMS sets reimbursement for your more efficient peers, that's going to be a major hit. So while there is risk in participating in voluntary APMs such as BPCI Advanced, there is also major risk in sitting out. With that, we want to ask our last poll question of our WebEx, which is downside risk a barrier in your past or present future decisions to participate in voluntary alternative payment models? Yes, it is a major barrier. It is a barrier, but not the only one. Maybe it's not a barrier, or you're just not quite sure yet. Yeah, this is really interesting. So about 2/3 said this is a barrier, but not the only one. About 17% said it's not a barrier, and then another 17% said they weren't sure yet. For providers who are interested in direct contracting with CMS or facing downside risk in a value-based care program and have interest in protecting themselves from losses, there are innovative insurance products available on the market today. These might be stop loss or provider excess insurance that will cover this downside exposure. Archway has partnered with an A-rated insurance carrier to launch stop loss for providers and encourage you to reach out to your insurance broker to learn more about your options. And then lastly, before we open it up for questions, Archway has data for all providers in the country, and we've put together a BPCI Advanced Scorecard so we can give you a sense of, at least preliminarily, what your opportunity looks like in any of the bundles in BPCI Advanced. So reach out to us today at info@archwayha.com to request your BPCI Advanced Scorecard. And with that, why don't we open it up to Q&A? I know we're running a little short on time. Perhaps McKenna, you could review any questions that may have come in during the webinar.
Yeah, thank you, Keely, for that fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. So it looks like the first audience member is asking, what is the source data for creating your regional benchmark? If it's LDS, how do you estimate Part B?
Yeah, so Archway actually has ResDAC data, so we actually have 100% Part A and Part B. Now, I will say with LDS, the LDS, which has 5% Part B, that 5% is a very robust representative section or sample of Part B that is deliberately selected to be representative. So LDS is also a strong source of data when doing regional benchmarking as well.
Great, thank you for elaborating on that, Keely. The next question is, how does Cohort 2 differ from Cohort 1 of BPCI Advanced, and what makes it more attractive? One big difference is that CMS has added new bundles to the program for Cohort 2, which go live on January 1 of 2020. They have added TAVR, or I should say they've differentiated TAVR from other cardiac valve procedures. They added outpatient knees to the major joint replacement of the lower extremity bundle. And in Cohort 1, major joint replacement of the lower extremity could only be triggered by MSDRGs 469 or 470, so these were done in the hospital inpatient setting. Now, with Cohort 2, if you do outpatient knees in the hospital outpatient department setting or total knee replacements that are paid for under hospital OPPS, those will count in your volume in BPCI Advanced with Cohort 2. CMS has also added an alternate quality measure set to give providers more flexibility as far as which quality measures they want to be scored in. So those are some of the examples of differences in Cohort 2. Wonderful. Thanks for sharing some of those examples. It looks like we have time for one more quick question. And this audience member asks, do you see hospitals creating a narrow network with high-performing post-acute providers and including them in gain sharing?
Yeah, yes, we do. We've had a lot of success in helping hospitals set up narrower networks of preferred providers. There are some who are sharing gains and some who are not. It's not necessarily the case that you have to share in gains to have strong collaboration with a preferred provider network. Going through a MOU and stakeholder process in which you review expectations and goals for improved patient care can lead to strong alignment and collaboration. Some areas have chosen to gain share as well.
Thank you for clarifying that. Now, before we go ahead and end today's presentation, let me just turn the floor over to you one more time, Keely, to see if there are any final thoughts that you'd like to share.
Sure. So I would remind folks that you have another month until June 24th to either submit a non-binding application or be listed on a convener application such as Archway's. And this will allow you to preserve your option to participate. It doesn't mean you have to, but it preserves your option to participate and importantly gets you the access to a lot of really rich intelligence, claims data, all Part A and Part B for your patient population that can be used to identify opportunities to improve patient care. This data would otherwise not be available to you. So at a minimum, we really encourage you to apply to get your data because this is really going to be the last opportunity. And as we expect to see more and more mandatory programs come down the pike, and historically mandatory programs have not included a big data dump ahead of time, having this data might be helpful for those other APMs as well. So please reach out to Archway if we can be helpful in helping you navigate this decision and Cohort 2 application process.
Wonderful. Well, that is all the time that we have left for today. I want to thank Keely for her excellent presentation and Archway Health for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.